Good afternoon, everybody, and thank you for having us here to present to you today. I'm glad I can only see my slides and not the number of people and all the names of people who are much smarter than me who are watching this presentation. It makes it a little less intimidating. But my name is Azim Kazmani, and I'm here with Anthony, and thank you for the kind introduction and the invitation to speak to you today. And we'll be talking to you about COVID-19 management in personal service settings, lessons learned from a nail salon outbreak that we experienced here over the summer. Before we begin, I'd like to start with a land acknowledgement. The area that I'm in right now, Kingston specifically, is the traditional lands of the Anishinaabe and the Haudenosaunee peoples. And it's also known as a dish with one spoon. It's got plentiful natural bounties and resources, and so many of this region's First Peoples would come to the area. I apologize for some of my pronunciation, but the land acknowledgement here we use at KFL&A. I'll begin with that. So, Sego ani buju wacheya kwe. I offer these words in the spirit of this gathering. Let us bring our good minds and hearts together as one to honor and celebrate these traditional lands as a gathering place of the original peoples and their ancestors who were entrusted to care for Mother Earth since time immemorial. It is with deep humility that we acknowledge and offer our gratitude for their contributions to this community, having respect for all as we share this space now and walk side by side into the future. And of course, many of you are tuning in from different areas of the country, and so we all respect the lands that we are on and offer acknowledgements. For our disclosures, we have none. I'm a resident here at Queen's, and our contract is paid through the local hospital, KHSC, doing rotations here at KFL&A Public Health, and Tony is a medical student at Queen's who did some paid work at KFL&A Public Health over the summer. We'd like to take a moment before we begin to thank the staff at KFL&A Public Health, as well as many of our community partners. This isn't an exhaustive list, but certainly the local hospital systems at Kingston Health Sciences and Lennox and Addington County General Hospital, and our local public health lab and colleagues at Public Health Ontario. We're very, very supportive through this process. This is one of those experiences that, or as everybody knows, having dealt with COVID now for so long, you can't deal with it in isolation or in a silo, so thank you to everybody. And we'd also like to acknowledge all the individuals and organizations who've been affected by this outbreak and the COVID-19 pandemic and continue to be affected, especially as we go into seeing more and more cases across the country. Of course, special thanks to Dr. Moore and Dr. Hugh Guan, who led us through this process. And certainly it's a privilege for me to be training under someone like Kieran Moore, learning firsthand through experience how to respond to outbreaks, how to risk communicate, really be a leader in a community. It's certainly a privilege. I'll turn it over to Tony now.
Perfect, thanks Azim. So as an overview, testing, can people hear me?
Yeah, we can hear you.
Oh, great, sorry. Yeah. So as an overview, we'll be walking through the background information about the KFL&A region and the setting prior to the outbreak. And then following that, we'll be talking about our investigation and management approach. So if we go on to the next slide, KFL&A, or Kingston, Frontenac, Lennox, and Addington region, has had a very low community incidence of COVID-19. Prior to the outbreak, despite having a population of roughly 200,000 with 20% of individuals aged over 65, we had 0 attributed deaths, only 1 case in a long-term care home, and 63 total known cases. In the region, our major employers include the military, prisons, and healthcare. To better geographically situate exactly where we are, Kingston is in the middle of higher prevalence regions. The US border is very close, and we're a stop along the way during travel between Toronto, Ottawa, and Montreal, and this allows for a high risk of spillover from these other areas. So we can move on now to a timeline for the outbreak. Ontario had a 3-stage reopening plan for the economy, which allowed for a gradual reopening of business and spaces. On June 12th, KFL&A was allowed to move from phase 1 into phase 2. Now, what was particular about phase 2 is phase 2 allowed personal service settings, such as nail salons, barbershops, and tattoo parlors, to reopen. These personal service settings were given guidance and best practices on use of face coverings, hand hygiene, cleaning and disinfection, and importantly, the record keeping of clients. However, these were not mandated. In addition, the provincial regulations did not require any inspections prior to reopening, and this was a considerable gap that we'll touch upon in the coming slides. So on June 20th, this is a week after, a hospital staff member tested positive for COVID. As mentioned, this was 1 week following phase 2 of reopening. And given that KFL&A had had no new COVID cases for the 3 weeks prior, this caught everyone's attention. This was especially concerning given that the case was a hospital worker and there were worries about a hospital outbreak.
Yeah, if I can just jump in quickly for that. We tested everybody in the hospital, all the contacts, all the patients that hospital worker had worked with, everybody that they had come into contact with in break rooms, everywhere else. And at that point, that was right when the hospital had implemented universal masking for almost everybody, and nobody came back positive. So it was quite puzzling, and common things being common, our initial thought was this must be related to the hospital. And so it was quite concerning at the time.
Right, and with all the hospital staff and patients testing negative, and they were followed up after testing and none developed symptoms, case and contact management, we were just searching for a source over the next coming days. Several days later, 2 more positive cases were reported, and neither of them had a connection to the hospital or the initial case, and none of the 3 reported each other as contacts nor identified any shared contacts. So after repeated case interviews and social network analyses by case investigators, a common link was discovered, and all 3 of these cases had visited the same nail salon the week of June 14th, which was the week that phase 2 reopening had occurred.
There was a bit of an aha moment around here.
Exactly. And so immediately as soon as that was identified, we rapidly deployed an inspector and nurse team on site to investigate the personal service setting. We tested all workers, we reviewed IPAC practices immediately.
So some of the lessons learned here was the classic interview technique we hear about when we do outbreak management was a single interviewer picking up on patterns and noticing, oh, this person said something. And then hearing when they do the next one, which often in foodborne outbreaks, when we review those in studying, we hear about. But here, this was a real life example of that. There were teams and different individuals calling, but we would review these cases because we had only the 3 cases at the time. And it was through that review as a team that we were able to do these, to gain that pattern recognition and then specifically follow up. And initially, when we were going through the process, we had to be really careful because we didn't know much. This, looking back, it's easy to say, but moving forward, it was hard just having 3 cases. They may have been to the same nail salon. So 1 was finding out more about that. And 2 was when we talked to other people or other cases as they came forward, even moving forward, we'll see a number of cases that popped up that initially may not have been close contacts, or they just may have been people who went in sick. It was important not to narrow it down too much and say, did you go to XYZ nail salon or did you go to XYZ establishment? Because it could have been that someone went to a nail salon and then they went and got a massage, or it could have been that this was an issue across multiple personal service settings in the region. And we also, before we had proof at this point, we didn't want to name and shame anybody. That's never the intention of this. It's solely to make sure that the public is aware of the risk. So balancing some of that communication was really important. One other thing is that we were in charge of the testing and assessment center at the time, as the public health unit. So we had access to PPE, we had swabs, and we had the human resources, which really facilitated the rapid testing. We also assigned an outbreak number, which in Ontario is a way to get prioritized testing for important testing events related to outbreaks. And as a result of that, it really facilitated the speed at which we could test and get results back. That on-site testing, I think, was really important because we were able to go on site We were able to get people done right away. They didn't then have the opportunity to not show up for an appointment, and it really increased the complacency. So we know the vaccine framework is if complacency, confidence, and convenience. Well, this really made it convenient and reduced complacency in a similar way. So that really helped us get our numbers of those employees up. It reduced delays and it really expedited everything. We then, as Tony described, we had an IPAC investigation where we noted a number of things, including improper face mask use by both clients and staff, including where it wasn't covering the face completely monthly. And at the time, this was a new practice. Face masking wasn't as widespread as it is today, but we still continue to see these gaps in public. Hand hygiene wasn't up to standards. They weren't always using soap when washing hands, employees, and they were only washing their hands briefly at times. Staff, just going back to hand hygiene, the other thing is at a nail salon, I must admit, I haven't had my nails done, but from speaking with people who have, you want to let your hands dry afterwards. And so immediately, even the customers weren't necessarily washing their hands, just as part of the routine practice when they get their nails done. As well, staff weren't always, it didn't seem to be appropriately screened for COVID-19 symptoms, and some of them appeared to be symptomatic when we were there, which is also why we tested them. And the workplaces, equipment, they weren't cleaned as per best practice guidelines recommended in the prevention of infection and control guidelines. So eventually it came back that 6 of those 10 employees who worked there tested positive, and an outbreak was declared and the nail salon was ordered to close until further notice. Now, when we did our inspection, based on the symptoms and based on the findings and the fact that 3 people who tested positive visited there, that's when the order to close was given, and then the tests were available later that day or the next day. Again, the client list that was provided by the nail salon for the people who had come there to record who's there. We do this now with restaurants and other personal service settings where anyone who comes in records their name, the date and time they were there, and their contact information to facilitate contact tracing after the fact. But it was really not adequate, that record keeping there. So it was incomplete, it was illegible. There wasn't contact information available for everyone. The times they were there wasn't available for everyone. And so we had a really tough time determining who had been to the establishment based on those. As a result, we had to disclose publicly where the establishment was, and said anyone who had visited between June 12th and June 24th was required to quarantine for 14 days and go get a COVID-19 test due to the risk of the situation. Again, at this point, we just had 3 people who had come back positive. We had 6 employees there. They had treated over 500 people, and we had no idea how many people this would affect or how large of an outbreak this could end up being. So ultimately, over 500 customers were found to have visited between June 12th and 24th, so quite a lot. And again, this was the first time things had opened up since March, April. And so really people were looking for a little sense of normality during that time, and a lot of people found that this was something that they could do, go get their nails done like they otherwise would, and you can't blame anybody for wanting that after being cooped up for so many months. But quite a large number of people. We also, by the end of it, determined that there were over 180 close contacts of the positive cases who were required to quarantine and obtain testing, in addition to those 500 who had visited. Of the individuals who had visited, there were at least 34 healthcare workers from the region's main hospitals. There were 43 healthcare workers from long-term care and retirement homes. It affected municipalities, enforcement services, emergency services, retail, restaurants. The majority of clients were female, And so there was a significant impact noted on jobs and workplaces in general, but especially those that relied on traditionally female-oriented roles. And many places of work, including long-term care homes and the hospitals, face significant human resource shortages as a result.
So with the high number of contacts and to minimize the risks of additional outbreaks in public settings, 2 days after the public announcement on the 25th, on the 27th, the local medical officer of health, Dr. Moore, issued an order with two mandates. The first was that all commercial establishments have alcohol-based hand rubs or hand washing stations available at entrances, and the second being the required use of face coverings or masks indoors in all commercial establishments. So our case and contact management team and social network analyses identified that some staff of the initial nail salon worked at other establishments, and that many of the staff were close contacts with staff of other salons. Symptomatic clients of these other nail salons tested positive as well. Eventually, 3 nail salons in total were ordered to close, and all received similar IPAC visits as the initial outbreak source. All clients were publicly asked to get tested and quarantined for 14 days.
So some of the lessons we learned here were that aggressive outbreak management is really important. Testing, tracing, isolating was really important to break that chain of transmission. As we talked about the inspections on site and making that testing accessible and easy was really important here to detect who had it, how wide this was affected, and who needed further follow-up. Communication was another important factor. We'll go into a little bit more about that later, but being open and honest with the public as well as your stakeholders is really important. So that includes all the hospital partners, healthcare partners, primary care partners, your emergency services, all the industries that are affected. So police, fire, EMS, for example, who had workers, long-term care, retirement homes, as we had known by then that this disease, especially in those congregate living settings, was heavily, causes quite a bit of morbidity and mortality, and there were workers who had been there. So lots of areas of concern there. The other big thing was finding models that work. So the PHI-PHN team who goes and inspects on site, that's something that we have done early on in long-term care homes and found to be quite successful. So using a similar model here was the next natural step in our outbreak management, seeing that translating from one setting to another, but using the same concept and then working the details out that are needed for the specific situation, and then sharing lessons learned with our provincial partners. Tony actually has written a manuscript which he submitted for publication as well, describing the situation and the lessons learned. And in sessions like this, we're certainly grateful for the opportunity to come present and share our experience.
So just as a brief overview of our case and contact management process, each individual was asked about onset date, symptoms, exposure history, risk factors, and close contacts with that level of exposure risk. And following our provincial guidelines, all cases were actively monitored for a 14-day period. All individuals testing positive for COVID were contacted within 24 hours, which allowed for rapid contact tracing and isolation of cases and contacts to really contain the outbreak. The testing turnaround time varied between 24 and 48 hours, but the onset direct testing at the outbreak source was really crucial in reducing that. The case definitions that we used, well, for a COVID-19 positive case, it followed the ministry definition as individuals with a positive PCR, a single gene target. And we also used an internal case definition for this outbreak as clients or close contacts of clients of the initial nail salon. So to take a look at the impacts as a whole, between June 20th and July 3rd, we had 37 cases in total. As mentioned before, the majority were female, and our average age was 38.6 years, our youngest being an 11-month-old and the oldest being 69 years old. It really impacted various occupations and many sectors of society, and there were 7 who were asymptomatic at time of diagnosis. 3 of the 7 asymptomatic cases never went on to develop symptoms of COVID, and there were 2 cases of transmission that were identified from an asymptomatic individual. There were no deaths associated with this outbreak as well. Moving on, this is an epidemic curve following the testing dates of positive cases. If you take a look at that red X there on June 25th, that's the date that we visited the outbreak site and really did everything. The cases came forward from there. Of those 10 cases, 6 of those were the staff that worked there, which tested positive, and 4 more were additional contacts. And we can see following the 25th, cases were identified as testing increased. Of those 37 cases, 14 were from direct exposure through the personal service setting. 12 were household contacts with that first generation, and the rest were social or workplace contacts with the case. And at this time, this really represented about half of all the cumulative cases in the region since the discovery of the virus. You can see in this graph that there really was a large portion of cases for this outbreak, and it was essentially our second wave.
So moving on to the outbreak management, some of the lessons learned. The thorough source finding and contact tracing was really important here. I think we've gone through it a bit, but finding out that when we had those 3 cases going back to this nail salon, that was really an important spot for us, because we have seen, and multiple times it's been confirmed around the world, just as it was with SARS-CoV-1, that quote-unquote super spreading events are the main ways that this illness spreads. The majority of people who have it don't seem to spread it to other people, but some people spread it to many. It's unclear whether there's a biological reason for that, but we do for sure know that situational factors can increase that. And the larger the amount of contact, the close personal space, the proximity, those certainly are all impacting events. Within this, we'll go into it a little bit later, but there was another super spreading event where one of the initial clients of the nail salon, and they were one of the 3 who was actually identified, ended up leading to a subsequent chain of transmission of 14 additional cases. From what we can tell based on our case contact management history taking was that there was a party of sorts that was held. It was indoors, there was alcohol, and there was close prolonged contact there. I'm not sure. I know there's been some questions about ventilation, and as far as we understand, it may have even been in a garage, and so there wasn't good air spread there. The role of alcohol and whether people are either disinhibited, more prone to close personal contact, whether there's more spit or saliva as people talk. It's hard to know for sure, but certainly that was an event that led to a number of cases. As we look back as well, we can note that only 1 case required hospitalization, and that was an individual with prior comorbidities. We took a multimodal approach to swabbing, and I think testing is a really important part of the outbreak management, and testing widely, broadly, and making testing accessible, as we talked about. So we had our fixed assessment centers, which we ran and partnered with in Napanee, which is outside our area of the Lennox and Addington County General Hospital. We also set up drive-through testing capacity. Since that time, I think there's also been our paramedic services have been helping us. We had primary care partners who did some of our initial testing as well. And then we also did the targeted testing at the outbreak site. So finding out how widespread the problem was very important. And I think we've seen this elsewhere as well in other experiences. At that time, anyone who wanted a test in Ontario could get a test, and there were no limiting criteria. There was quite a bit of concern in their community, which led to really high rates of testing. As you can see, there was over 10,000 tests done in KFL&A by July 7th. At the time, the weather was nice. It was first come, first serve. People were lining up outside to get tested, and people well beyond those who had either attended the salon or been or were close contacts of someone who had attended, wanted to get testing, and they could. So it was quite a broad net. It's now looking back, it's probably easy to say that it was a bit too broad. With our current epidemiology, lab capacity, resources, etc., we would probably be a bit more narrow. But it's hard to know when you're looking forward at something, seeing how many new cases a day, how many people had visited, etc. But essentially, for every positive, we had done over 270 tests, and the percent positivity was 0.37. Talked a little bit about communications, and here's a snapshot from a video Dr. Moore did, and still continues to do these Ask the MOH videos on a regular basis, where the public can then see what he's thinking. And I think that open, honest communication is really, really important. Letting them know what we know so people are aware, and that really gives them confidence. We also had and still continue to have a COVID call line where anybody in the community can call us and ask questions. It's staffed by nurses or other staff, depending on the needs of the question. And as a result, there's always someone accessible for the public when they have concerns. We had regular press releases, traditional media interviews, and I think it made some national media as well. And the stakeholder teleconferences. So this is another really important thing that I think needs to be highlighted. There's a weekly call, and it continues to this day with our local municipal partners at the higher level, and then there's multiple smaller calls at lower levels, enforcement, EMS, with our partners like the universities in town, and the healthcare team. So there's the primary care, there's the acute care sector, there's regular conferences to keep each other aware of what's going on, what's happening, gain intelligence, but also stay on top of things and provide a consistent message. So the general public doesn't necessarily see a difference between these various divisions in the healthcare sector. And so when somebody tells them, oh, not my job, oh, I don't know, they really lose confidence. And so keeping on the same page is certainly an important role. And those stakeholder teleconferences really help with that.
So after the outbreak, we constructed a social network analyses from our case contact management investigations, mainly just for data visualization purposes. And if you look right in the middle for that black square as the nail salon, we can see that the personal service setting itself was a super spreading event with 14 cases. The green circle was the index case in the hospital staff worker. Those 6 blue circles are the initial staff cases. Red circles indicate non-staff cases, and we can see the types of transmission with the black or green arrows, as black being contacts, regular contacts, and green being household contacts. Of interest is the black diamond, which is the additional super spreading event that we mentioned. You can see it resulted in 14 additional cases, which was really over 50% of all the case burdens, and it continued to second and third generation transmissions. I talked about generations, and the next slide shows the 4 generations of transmissions that we identified. First generation, moving on to the 4th generation, we had a decrease in cases and a decrease in contacts, which is what we would expect and hope for as individuals self-isolate for 14 days and avoid contacts, and the attack rate decreased accordingly from the 2nd generation. As Azim mentioned earlier, a multimodal approach to testing, as well as frequent public communication, resulted in this really huge increase in patients being swabbed following the STAR. So the STAR is the index case, and we can see that the call center volumes similarly went up as well.
So again, the lesson learned, just to harp on it a bit more, that source finding is really, really critical. And so linking everything back, as you can see here in this image, not many of the cases actually led to subsequent infections, and some of the ones that did may have been were usually within close personal contact and household contacts. And then because we were able to do contact tracing, we were able to halt those chains of transmission. But you can see that one person or one party led to 14 cases there. But very many of the people didn't end up transmitting it along, which is quite relieving. But source finding is something that we take very seriously. For every case that we get now, we try to find the source, we try to see, and then for the subsequent cases that come in, we try to find if there's any connection. If somebody says that they went to X place, especially if we don't have a good source. So if somebody says, oh, in Kingston, oh, I went to Toronto, where we know there's a higher burden. Oh, did you interact with anybody there? Yes, I had lunch with my friend, and then they'll ask the friend to get tested, and oh, the friend's positive. There we have our connection. Or they may be that, oh, I went there, my friend's positive, and now I'm positive. We have a connection. But when we don't have that, we try very aggressively to find out where someone got it, because if they got it from there, the chance is that other people also acquired the virus from the same place, and we want to do our best to halt these outbreaks or super spreading events. The one advantage we have in KFL&A is that we have a highly compliant population and adherent community. Everybody will often ask how we do so well. We're just the messenger, and certainly it's up to the community to do the hard work, to limit their contacts, to keep their distance, to wash their hands, to wear their masks. And our overall compliance in this area is very, very good. Moving forward from this, again, we didn't know, does this affect other personal support service or personal service settings within our jurisdiction? Is this a more broad pattern that we're missing? We didn't see any case reports or any other outbreak reports similarly on SIN-FI or anywhere else, but as a result, we again took the same model we had used and expanded it. So we identified all the personal service settings in the region. We asked them to complete a mandatory audit checklist, and then we did a risk-based stratification based on their responses to the checklist, what they had in place in terms of their preventative measures, and we also looked at our history of working of inspections in general to find out where we had had trouble in the past. And so based on the risk stratification, certain establishments received an IPAC inspection by a PHI/PHN team, similar to we did here and similar to how we've done with our long-term care homes and retirement homes as well. And so that helped identify other issues. And then we shared this, our experience and our approach with the province, with other jurisdictions in Ontario, and as well as on SIN-FI. I had a couple of, I had some more information here on just, it seems to disappear, but I think we laid 13 charges associated with the Reopening of Ontario Act, or the other, I think it was called something else at the time. I don't remember off the top of my head. But the Ontario regulations and through various other, either through the HPPA, which is the Health Promotion and Protection Act in Ontario. And so 13 charges, including these above mentioned closures, were included or were laid as a result of these inspections across the region. So again, the accessible testing, lab turnaround time is another really important thing. There was a period recently when schools came back and a lot of kids were getting tested that the turnaround time was 5 or 6 days. And I remember speaking to colleagues in jurisdictions within Ontario, but in southwestern Ontario, for example, and other areas where their turnaround time was 7 or 8 days. That makes containing the virus really, really difficult because you can't contact trace and break the chain of transmission. So we were certainly privileged to have 2 labs in our area. We had the Public Health Ontario lab in Kingston, as well as Kingston Health Sciences had a lab up and running. And so we had access to quick that lab access really allowed to expedite the turnaround time, which then allowed us to contact trace within 24 hours of a positive as per provincial standards. Again, the communication was really helpful. I think the public trust as a result of that increased significantly. And then our inspections, again, going on site, that was very helpful. Branching out to find other potential areas that could have similar problems, it was also really important in terms of a preventative measure, just like we had done in long-term care homes. And even still, as we get cases that are in high-risk areas or high-risk populations, we employ a similar model where we go do an IPAC inspection if needed and start testing on site. And as well, the mandatory face coverings, it gave our population something they could do to respond, something else they could do to feel safer. We were very clear that they were not substitutes for physical distancing, masks or face coverings, but certainly we've seen very good uptake here in our area. And so again, our caveats were that we're a low prevalence setting. I'm sure if we had 100 cases a day, our ability to go out and do these inspections, our ability to go out and do many of these preventative measures would have been very hard because we would have been working on case and contact management much more with fewer resources to do a lot of that preventative work. But there's also an argument that perhaps that preventative work prevented us from getting to that spot. The compliant population also is very, very helpful in this case. And so I don't think we could have done it without our community. Our overall key messages, really, I think everyone's seen Mike Ryan from the WHO talk about this, but be decisive, act early, and you can always reconsider your position as more information comes through. Better is the enemy of good. So I did my clinical training in surgery, and if you tried to futz around and get perfect, you could easily make a mistake. And similarly here, you don't want to wait. You don't want to give the virus time to keep spreading to get the perfect response. You want to get out there, you want to act and prevent its spread. And you can always reconsider things. And I know none of our responses have been perfect, but there's always a learning opportunity to improve for the next time. Again, knowing the source of the virus, where is it coming from? Where is it spreading within your community? If you can lock that down and find where one person got it, the chance is that multiple people have also acquired it from there. Making public health easy to access. So in general, beyond here specifically, getting testing easy to access, getting communications easy to access, making people have confidence in that, because the trust and confidence are really our most important currencies. And so that communication is really, really critical there. As we're as good as our word here, because we're just the messengers, and it's really up to the people who live in our communities to carry out and do the hard work as we talked about. And so as well, those pre-standing community relationships, that risk communication, it all helps when you're in a situation like we found ourselves in. So I think that's essentially what I have here. Happy to turn it over if there were any questions and answer, or hear any comments. Or